Hey students, today we're going to talk about the endocrine system. So both the nervous and the endocrine system are methods of communication. The endocrine system specifically uses chemicals called hormones. These are made in the ductless glands of the body, the endocrine glands, and released into the bloodstream and transported through the blood to all the parts of the body. Now, because they're going everywhere, and we don't necessarily want the effects of every hormone on every cell, cells will have receptors on them. We call those target cells. Those target cells have the receptors that will bind and respond to a specific hormone. And this is the part you're going to hate. The target cell for a specific hormone just depends on what hormone that is. Some hormones have very, very specific target cells only found in one or two locations of the body. Other hormones have target cells pretty much everywhere. The endocrine and the nervous system both release ligands, or chemical messengers, which then bind to those cellular receptors on particular target cells. The nervous system is very, very targeted. We're using those ligands right on the synapse, those neurotransmitters. Whereas with the endocrine system, it's very, very general because it's going everywhere in the blood all at once. The nervous system is extremely fast and it's targeted, whereas the endocrine system is slower. The effects are more widespread, and the reaction time is longer, and the effects last much, much longer than your typical neurotransmitter. Now, the endocrine system helps to regulate development, growth, metabolism. There's hormones that do all kinds of things in the body. Hormones help regulate blood solute concentrations of different things, for example, glucose or ions. They help regulate blood volume. They help with cellular concentration of ions. They help with platelet numbers. They control digestion. They control the reproductive activities of the body. Endocrine glands contain epithelial tissue that actually makes and then releases the hormones within a connective tissue framework. Some glands are specifically endocrine only. These include the pituitary gland, the pineal gland, the thyroid, the parathyroids, and the adrenal glands. And then some endocrine cells are found in clusters in other organs. For example, the hypothalamus, the skin, the thymus, the heart, liver, stomach, pancreas, small intestine, and adipose connective tissue, kidneys and gonads, all have endocrine cells within them, even though they're not specifically sometimes endocrine organs. To release a hormone, which is a signal, we need to specify or control that release. So there's three ways that we control these, three different systems. One is a hormonal stimulation, one is a humoral stimulation, and one is a nervous stimulation. So hormonal stimulation means that another hormone is going to trigger a specific gland to make its specific hormone. So hormone A would affect gland B, which would then make hormone B. Get used to this idea. There's lots of places in the body where we chain these together. So we have gland A and B and C, and A makes hormone A and gland B makes hormone B, which then affects gland C, and then hormone C eventually goes and affects some target tissue. Why is this so complicated? Because it allows us better levels of control. Humoral stimulation has to do with the humors of the body, which are the fluids, in this case, blood. We're looking at levels of different things in blood. For example, calcium levels in blood are a trigger for the release of something called parathyroid hormone. Levels of glucose in blood are a trigger for the release of a hormone called insulin or a different hormone called glucagon. So that's humoral stimulation. And then finally, nervous stimulation is where the nervous system gooses an endocrine gland, which then produces its product. Now, as hormones circulate in the blood, they're made out of a variety of substances. One of these is steroid-based hormones. These are lipid-soluble, and they're made from cholesterol. Cholesterol is 4 interlocking chains of carbon atoms. There's 17 carbon atoms together, so sometimes these are called the rings of 17. Steroid hormones include the gonadal steroids like estrogen, testosterone, progesterone. They include steroids by the adrenal cortex, for example, cortisol. Biogenic amines, or monoamines, are modified amino acids. These include catecholamines, thyroid hormone, melatonin, and most of these are water-soluble except for thyroid hormone. Finally, proteins can be used as hormones. These are water-soluble chains of amino acids. Some of the hormones are produced locally. These are called autocrine or paracrine hormones. Autocrine would affect the same tissue that's producing it, whereas paracrine hormones will go and affect a small area around the tissue. We're going to focus mostly in this class on the endocrine hormones, which freely circulate in the blood and gall all over the place. Eicosanoids are a type of hormone formed by fatty acids. Prostaglandins specifically stimulate pain and inflammatory responses. Aspirin or other non-steroidal anti-inflammatory drugs, or NSAIDs, specifically block the formation of prostaglandin. So here is a map of eicosanoid production, where we're going to, on the plasma membrane, take a 20-carbon fatty acid called arachidonic acid, and we're going to change it into some of the eicosanoids. For example, prostaglandin or thromboxane or leukotriene. All of these are inflammatory chemicals. Now, as hormones travel in blood, the ones that are lipid-soluble, of course, are nonpolar, so they don't really dissolve readily into blood, and so we're going to have to use some kind of carrier molecule to take those lipid-soluble hormones around. The carrier helps to protect the hormone from destruction. It binds to it and carries it around, and most of the hormone that we find in blood, about 90% or more, is bound hormone. It's on its way to whatever the target tissue is. Only free hormones are able to exit the blood and then bind to target cells. So once that bound hormone gets toward the target tissue, it's going to disengage from its carrier and then diffuse into a cell. The water-soluble hormones, the ones made out of amino acids or small proteins, don't really have to use carrier molecules. When we look at how much hormone is circulating in blood, we have to take several things into account. First of all is the level of hormone release. So the more hormone that is released, or the faster a hormone is released, the higher the level in the blood is going to be. Hormone elimination occurs in several different ways. The hormones can be broken down by enzymes in the liver. They can be removed from the blood by the kidneys and excreted, or taken up by their target cells. And the faster the elimination rate, the lower the blood concentration is going to be, and vice versa. So all hormones have a half-life. It's the amount of time that it typically takes for a certain amount of hormone in the blood to decrease by half. It depends on both its release and how efficiently it's eliminated. Hormones that have short half-lives have to be released much more frequently to maintain their concentrations. The water-soluble hormones tend to have a short half-life, whereas the steroid hormones typically have a long half-life. For example, the half-life of testosterone is about 12 days. Now, lipid-soluble hormones can diffuse right on across their target cell membrane. Remember way back when we talked about membrane transport? This is one of the reasons why I really emphasize it, is because we're still talking about it. We will not stop talking about it. So lipid-soluble hormones diffuse across their target cell membrane. They tend to be small, nonpolar, lipophilic, and the receptors are actually inside the cytosol or the nucleus of the target cell. Once the hormone is inside the cell, it's going to bind to a receptor and form a hormone receptor complex. That hormone receptor complex will then bind to a hormone response element of DNA, and we're actually going to change the expression of DNA within the cell. So the DNA in the cell controls everything, right? Metabolism of the cell, secretions of the cell, functions of the cell. So when somebody asks you, hey, I met a totally legit businessman on the internet and want to buy some steroids off him, your answer should be, oh, hell no. Water-soluble hormones use membrane receptors. These hormones are polar and therefore can't diffuse through the cell membrane. Now, because of that, we have to have a little kind of complicated process called a signal transduction pathway. The hormone is the first messenger of the pathway. It initiates the event. it typically binds to something called a G protein that's present on the membrane. That G protein activation then causes an enzyme such as adenylate cyclase or phospholipase C, and that will activate a secondary messenger. That secondary messenger is present inside the cytosol, and so even though the hormone has not entered the cell, the message or the signal is now inside of the cell. So after a hormone binds to its receptor, that G protein is activated. The G protein then activates adenylate cyclase. Adenylate cyclase generates something called cyclic AMP, which then activates a protein kinase, and then the protein kinase phosphorylates other molecules, and that either activates or inhibits them. So it's almost like a complicated doorbell. You push the button on the outside of the house, and all kinds of things happen inside the house. The dogs start barking, the kids run for the door because the dogs are barking and the kids are running, the parents start yelling, and there's these cascading effects that happen. Now, water-soluble hormones can have different results with different signal transduction pathways. We can activate or deactivate enzymes. We can activate growth of the cell. There's cellular secretions that can be released. Membrane permeability can be changed, and muscles can be contracted or relaxed. Something really interesting happens with these secondary messenger systems. We can get what we call an intracellular enzyme cascade. And this is where every step in the process is going to amplify the signal. Now, target cells have a degree of response. And for our water-soluble hormones, that's going to depend on the number of receptors on the surface of the cell for that hormone and how well that cell is responding to other hormones that might control those receptors. So this is a really cool concept here, which is called upregulation and downregulation. So upregulation means that the cell is actually going to express more of the receptor proteins on its surface. Therefore, it's going to bind to more of the hormone, and the hormone is going to have a much stronger effect on that particular cell. Downregulation is just the opposite. The cell is going to reabsorb some of those receptor proteins so that there are less of them expressed on the surface of the cell, and therefore the hormone will have a lesser degree of effect on that cell. This is one way for the cells to kind of maintain their own little levels of homeostasis. For example, if we have a hormone that is lower than normal in the blood, then we could upregulate the cell and the effect would still be the same, would still be within homeostasis. Or if we have too much hormone in the blood, we can start downregulating and still keep our normal level of effect. One example of up and down regulation is sensitivity to glucose. Let's pretend for a second that as students, some of you have multiple jobs and take care of families and don't have very much time to cook a nutritious and balanced meal. Just work with me here for a minute, okay? As you choose a really fatty and sugary snack and eat it, you're asking your pancreas to produce a hormone called insulin. Insulin is the hormone that causes the cells to make glucose receptors to bring the glucose into the cell. Without the insulin, those receptors aren't there and the cell cannot bring glucose into it, therefore it can't make ATP and it will eventually die. So as you bomb the pancreas with this super sugary snack, the pancreas is going to make a whole bunch of insulin very quickly to decrease your blood glucose to get it back to normal. The problem is all of this insulin is kind of ramming it into these target cells, ramming the glucose in. And so these cells start to downregulate their insulin receptors. And then you eat another sugary snack and the same thing happens. And after you downregulate for a while, the cells start to become what we call resistant to insulin. This is how type 2 diabetes starts. You can upregulate your insulin receptors by exercising. When you exercise, you upregulate the insulin receptors because the cells are going to be more metabolically active. They need to make more ATP. So it makes sense that they need to bring more glucose inside of them. So type 2 diabetes can be treated very, very effectively. I can't really say cured, but it can be treated to the point where you no longer need medication by exercising and eating healthy meals. Now, as hormones interact with each other, sometimes they will boost the effects of each other, and that is called a synergy. They're reinforcing each other's effects. So, for example, estrogen and progesterone tend to work together on target cells to boost their effects. Another idea is permissiveness, where one hormone allows the second hormone to work. For example, oxytocin causes milk to be expressed from the female breast, but first we have to make the milk with a hormone called prolactin. And then finally, hormones can be antagonistic. This is where their activities tend to oppose each other. And it sounds a little weird, but we're still keeping the body in homeostasis. I mentioned insulin. Insulin's job is to lower blood sugar, which is great right after a meal, but if you haven't eaten for a couple hours, your blood sugar is already kind of low. You need to raise your blood sugar, and so you're going to use another hormone called glucagon. Glucagon increases glucose in the blood, and then insulin is going to put it into the cell. So even though they have opposite effects on blood sugar, they have cooperative effects in order to keep you alive. Now I want to talk about the hypothalamo-hypophyseal tract. The hypothalamus is a structure in the brain, and just below it is the hypophysis, also known as the pituitary gland. The hypothalamus is going to release hormones that control the pituitary. The pituitary then, in turn, will release hormones that will control all kinds of other glands. For example, the testes or ovaries, the liver, the adrenal glands, the thyroid. The pituitary gland is divided into half. There is a posterior pituitary and an anterior pituitary. They are very different histologically. The anterior pituitary looks very similar to glandular tissue. We see structures like acini that we see in our regular glands, but the posterior pituitary looks like a weird cross between neural tissue and glandular tissue. The posterior pituitary is sometimes known as the neurohypophysis, whereas the anterior pituitary is called the adenohypophysis. So the hypothalamus is going to send neurons down through the infundibular, this little funnel here, this stalk that the pituitary hangs off of. And those axons are going to go all the way down into the posterior pituitary. And that's where we have our synaptic knobs. The anterior pituitary has a portal system with blood vessels that connect the hypothalamus to the anterior pituitary. Now, the posterior pituitary is the storage and release site. So the posterior pituitary doesn't actually make these hormones. They're made by the hypothalamus and released by the posterior pituitary. It's going to release two hormones that are really important, oxytocin and ADH. ADH is also known as vasopressin. That's kind of an older name for it. ADH helps to stimulate thirst and helps to prevent the formation of urine. Oxytocin is a really trippy hormone that does all kinds of things. It functions in uterine contraction, the ejection of milk from the breast, and emotional bonding. The hypothalamus stimulates the anterior pituitary to release its hormones. The hypothalamus is secreting releasing or regulatory hormones, and then the anterior pituitary will secrete its hormones into general circulation, and most of those hormones will then go to other target glands in the body. So the hypothalamus is going to release either releasing hormones or inhibiting hormones. The releasing hormones are going to tell the pituitary to release a specific hormone out into the bloodstream. The inhibiting hormone is going to inhibit that process. So the releasing hormones include thyrotropin releasing hormone, prolactin releasing hormone, gonadotropin releasing hormone, corticotropin releasing hormone, and growth hormone releasing hormone. The inhibiting hormones include things like prolactin inhibiting hormone and growth inhibiting hormone. So the names are extremely similar because we're talking about the same hormone released from the pituitary, or inhibited from the pituitary. So remember our two hormones from the posterior pituitary? Oxytocin and ADH. The anterior pituitary has lots more. There's thyroid stimulating hormone, prolactin, adrenocorticotropic hormone, the gonadotropins, which are follicular stimulating hormone and luteinizing hormone, and then growth hormone. So let's talk about these in detail. So I've shaded the slides here for each separate hormone. So we're going to talk about growth hormone for a few minutes, and then as the slide color changes, I'll be talking about a second hormone. So the hypothalamus is going to release either growth hormone releasing hormone or growth hormone inhibiting hormone. And that's going to tell the anterior pituitary to either release growth hormone or not. The amount of growth hormone releasing hormone released from the hypothalamus is impacted by someone's age, the time of day, their nutrient levels in their body, and how much stress and exercise they're dealing with. Now, of course, growth hormone causes the bones to grow. But growth hormone also does something else that's really, really critical, and that is it releases nutrients from storage. As growth hormone levels increase, we'll start to do something called glycogenolysis, or the lysis of glycogen. Glycogen is a temporary storage form of glucose. So we're going to break up the glycogen into the separate glucose molecules. Gluconeogenesis is the creation of new glucose molecules. So do you see both of these have something in common in that they're increasing blood levels of glucose? Glycogenesis is inhibited, so we're not going to be taking the glucose and making glycogen. We're doing the opposite, right? Remember, as the body attempts to do some kind of process, we're going to turn off anything that would do the opposite of that process. When it's time to do something, the human body is all in on whatever that process is. So in this case, we're trying to raise blood glucose. So glycogenesis is inhibited. Lipolysis is stimulated, so we're going to break down fats and use them for energy. And then lipogenesis, or the formation of fat, is going to be inhibited. And growth hormone is going to do all of these things. So the hypothalamus releases, say, growth hormone releasing hormone to the anterior pituitary, which then releases the growth hormone, which then goes to all kinds of target tissues. It's going to go to the liver, to bone, to muscle, to adipose, and it's going to have different effects depending on what those cells are. Now, growth hormone release changes with age. It decreases as we get older. And then we also have a spike of growth hormone right before we go to bed. We tend to have a spike of growth hormone, or an increase, during the evening, and that's because usually you're fasting throughout the night, your blood glucose is dropping, and we need to increase blood levels of glucose, and hey, that's what growth hormone does. Now, growth hormone deficiency is going to cause a disease called pituitary dwarfism. It can be because of inadequate growth hormone production, because of either a hypothalamus or a pituitary problem, and that's going to result in somebody with short stature and low blood sugar. Pituitary gigantism is the opposite. Too much growth hormone in childhood is going to cause excessive growth and an increase in blood sugar, and you're going to also get these enormous internal organs, and these people tend to die early if not treated. Now, if the increase of growth hormone is still present after skeletal maturity occurs, then that disease becomes acromegaly. So gigantism is the childhood form of too much growth hormone. Acromegaly is the adult form of too much growth hormone. Because the epiphyseal plates have already closed, the long bones don't get longer, but we still have intramembranous ossification. So we have enlargement of the flat bones and the irregular bones of the body. So the bones of the face and the hands and the feet will all increase in size. The internal organs will continue to increase in size. And these people also have high levels of blood sugar. Let's talk about thyroid hormone. The thyroid gland is in the throat, right underneath your Adam's apple, also known as the thyroid cartilage. It has lots of vascular tissue in it, so it's got kind of a reddish color. And microscopically, there's little areas called follicles filled with something called thyroglobin. The follicles house colloid, which is usually kind of a pink staining material. And then there's little cells around these pools of colloid called parafollicular cells, and those cells make calcitonin. So here's the thyroid in the neck. It's on the anterior of the trachea. And microscopically, here are some follicles. Nothing else in the body looks like this. These pink puddles here that you can see are the colloid, and then around the outside, we have the parafollicular cells that make the calcitonin. What happens is we're going to absorb iodine ions. We're going to transport them into the follicular cell, and then we're going to place them into that colloid, and the iodine and the colloid are going to bind together and then be taken up through endocytosis into the cell and transformed into what we're going to call T3 and T4. And then the T3 and T4 will be released into the bloodstream. Now there's a hypothalamic pituitary thyroid axis. So the thyroid will control the pituitary, which will then control the thyroid. Cold temperatures or pregnancy or high altitude or hypoglycemia or low thyroid hormone levels cause the hypothalamus to release thyrotropin-releasing hormone. Thyrotropin-releasing hormone then causes the anterior pituitary to make thyroid-stimulating hormone. Thyroid-stimulating hormone binds to the receptor of the follicular cells and triggers the release of thyroid hormone. The thyroid hormone comes in the two forms, T3 and T4. T3 is triiodothyronine, and T4 is tetraiodothyronine. The T3 and the T4 are transported in the blood with carrier molecules. So here's the hypothalamus producing thyrotropin-releasing hormone, causing the anterior pituitary to make thyroid-stimulating hormone, causing the thyroid to release thyroid hormone. So here's the key with some of these hormonal axes, is that if you're low in the last product, the thyroid hormone, you're not sure where the problem is. It could be that the pituitary is not making thyroid-stimulating hormone, but then again, the pituitary is only doing what the hypothalamus tells it to do, so maybe the hypothalamus isn't telling it to make thyrotropin-releasing hormone. So what you have to do then is you have to test for not only thyroid hormone, but you also should test for thyroid-stimulating hormone. If thyroid-stimulating hormone is very high, then the body understands that there's not enough thyroid hormone, and so the pituitary, in effect, is shouting at the thyroid gland, telling it to do its job. So in this case, the thyroid is having issues. If the pituitary is not making thyroid-stimulating hormone, then of course the thyroid's not going to make thyroid hormone. So if TSH is low, then it's a pituitary issue. T3 and T4 circulate in the body. T3 is the active form, but we tend to make a lot more of the T4. And the T4 is going to go out into the peripheral tissues and kind of sit there, and then when it's needed by the tissues, then the tissues will convert T4 into T3, which is the active form, so it can use it. Now, thyroid hormone is the body's major metabolic hormone. The more thyroid hormone you have, the more heat your body creates, the higher your temperature is going to be, of course. You're going to increase amino acid and glucose uptake. Cellular respiration is going to increase, and you're going to burn calories at a much higher rate. So thyroid hormone fosters the production of ATP in all the cells of the body. It causes the adipose cells to increase blood glycerol and fatty acids by breaking them down, and this helps spare glucose for the brain. I mentioned earlier how insulin is needed to move glucose into the cells of the body, and this is true for everything except the brain. The brain can get its own glucose. Thank you very much. And so thyroid hormone also increases respiratory rate, use of oxygen. Now, hyperthyroidism results from too much thyroid hormone, so the metabolic rate is increased excessively. You're going to start to burn fat for fuel, so you'll have weight loss, hyperactivity, heat intolerance. You're hot already, so if you're in a hot environment, it's very, very unpleasant. And this is caused by either taking T4, excessive stimulation of the pituitary, usually by a tumor, or loss of feedback control like we have with Graves' disease. This is then treated by removing part of the thyroid. Hypothyroidism results from a decrease in production of thyroid hormone. They'll have a low metabolic rate, lethargy, they'll be cold intolerant, and have weight gain. This can be caused by a decrease in iodine intake, a loss of pituitary stimulation, again, usually caused by a tumor, or destruction of the thyroid, such as with Hashimoto's disease, which is an autoimmune disease. A goiter is an enlarged thyroid gland, usually due to insufficient dietary iodine. That lack of iodine prevents the thyroid from taking the colloid all the way to T3 and T4, and so those parafollicular cells just continue to make more and more colloid. Goiter used to be fairly common in the US, but not since we started adding iodine to table salt. Calcitonin is produced by the parafollicular cells, and the stimulus for its release is high blood calcium or stress from exercise, and it will act to decrease calcium levels by inhibiting osteoblastic activity or stimulating the kidneys to increase their excretion of calcium in urine. Let's talk about the adrenal glands. The adrenal glands are located on the top of each kidney. They are retroperitoneal, so they're behind that peritoneal cavity. They're embedded within the fat and fascia around the kidney. They sit on top of the kidneys like little party hats. In effect, they act as a single gland. They have two regions to them. There is the middle, or the adrenal medulla, and there is the outside called the adrenal cortex. The adrenal medulla creates epinephrine and norepinephrine, and the adrenal cortex synthesizes a whole lot of things, over 25 corticosteroids. There are three levels to the cortex. They are the zona glomerulosa, the zona fasciculata, and the zona reticularis. There is an adrenal gland perched on top of a kidney. Here you can see the adrenal cortex with the different layers. There's a little capsule on the outside. The very top layer is the zona glomerulosa, followed by the zona fasciculata, and then the zona reticularis, which sits just above the adrenal medulla. The mineralocorticoids that affect a structure in the kidney called the glomerulus are made in the zona glomerulosa. The main mineralocorticoid hormone produced here is called aldosterone. Aldosterone helps us to retain sodium. Glucocorticoids are hormones that help regulate blood sugar. These are made in the middle layer, the zona fasciculata. Cortisol is one of the biggest players here. And then the zona reticularis makes some sex hormones. Androgens are male sex hormones made by the adrenal glands and then converted into estrogen in females, but the amount produced by the adrenal glands is less than that from the testes, which is why if you test a woman's blood, she'll have testosterone. Cortisol and corticosterone increase nutrient levels in blood. Cortisol is a stress hormone. It helps the body to deal with stress. Its release is regulated by the hypothalamic pituitary adrenal axis in this case. Stress, the later stages of sleep, or low levels of cortisol all stimulate the hypothalamus to release corticotropic releasing hormone. Corticotropic releasing hormone then causes the anterior pituitary to release adrenocorticotropic hormone, and then adrenocorticotropic hormone causes the adrenal cortex to release cortisol and corticosterone. Cortisol levels are regulated with a negative feedback system, which, by the way, is the system of choice for regulating most of the hormones of the body. So here again we have our hypothalamus producing our corticotropic releasing hormone. That's going to the anterior pituitary, causing it to release our adrenocorticotropic hormone. And then the adrenocorticotropic hormone is going to the adrenal glands and causing them to release the cortisol. The cortisol then is the hormone that will go and affect different tissues in the body. It will increase gluconeogenesis from the liver. It will cause adipocytes to lyse and release their fat and cause all cells of the body to burn protein. Cortisol levels fluctuate based on the time of day. We typically make more cortisol in the very early morning, several hours before you need to get up, because getting out of bed is probably the most stressful thing you're going to do during the day, and you need that cortisol to help you get out of bed. Cortisol causes target cells to increase blood nutrient levels. The liver is going to do its glycogenolysis and gluconeogenesis, but it will decrease glycogenesis. So in other words, it's increasing blood glucose and not doing the opposite. Corticosterone is used as a treatment for inflammation. It's an anti-inflammatory, but at high doses it has unpleasant side effects like increasing the risk of infection by suppressing the immune system, causing cancer, or increasing retention of sodium in water, or inhibiting connective tissue repair. Too much cortisol results in something called Cushing's syndrome. Cushing's syndrome is chronic exposure to excessive glucocorticoid hormones from people either taking corticosteroids for therapy or in cases where the adrenal gland is producing too much cortisol or corticosterone, and it's going to result in obesity, hypertension, excessive hair growth, kidney stones, and menstrual irregularities. Remember, blood sugar is consistently high, and so the cells have to deal with that, and you're going to start gaining weight. Addison's disease is adrenal insufficiency. It develops when the adrenal glands fail. You have a shortage of those glucocorticoids and sometimes the mineralocorticoids like aldosterone. Now, this could be because of lack of adrenal corticotropic hormone or lack of response to adrenal corticotropic hormone. Addison's disease will result in weight loss, fatigue, weakness, hypotension, and the skin will darken. Sometimes this darkening of the skin is referred to as a bronze diabetes. Therapy is administration of oral corticosteroids. Because cortisol is a stress hormone, people with Addison's disease have a very poor response to stress. They have a really hard time raising blood sugar. They have an immensely hard time raising blood pressure. And any kind of stress to their system can actually cause them to go into what we call an adrenal crisis, which is deadly. Their blood pressure can drop so low that they're no longer getting oxygen and glucose to all of their tissues. So, which famous US president in the 60s had Addison's disease during the Bay of Pigs nuclear missile crisis? That's right. John F. Kennedy was president during probably one of the most stressful periods in all of history, where the United States and Russia, in the middle of the Cold War, Russia parked 3 nuclear-capable submarines off the coast of Cuba within range of hitting US soil within just a few minutes of launch. And JFK had Addison's disease. It was a top secret at the time. All of the medical professionals treating him were sworn to secrecy because if the Russians had known that he couldn't respond to any kind of stress, they would have pushed even harder than parking nuclear submarines off the coast of Cuba. Adrenogenital syndrome, also known as congenital adrenal hyperplasia, begins in the embryo or the fetus, and it leads to an inability to synthesize corticosteroids, and that leads to an overproduction of adrenal corticotropic hormone. In other words, the anterior pituitary is again shouting at the adrenal glands to do their thing, and they're not listening. High ACTH causes an increased size of the adrenal gland and production of hormones with testosterone-like effects, and that tends to masculinize newborns. The hypothalamus initiates the neuroendocrine response to stress in 3 stages. The first is the alarm reaction, and that's the initial response involving stimulation of the sympathetic nervous system. We have epinephrine and norepinephrine, and then there's the stage of resistance, which is after you've depleted your immediate stores of glycogen in the liver, the adrenal glands will secrete cortisol to raise blood sugar, help the liver to make new blood sugar, and to start breaking down fats and proteins for blood sugar to help to meet the energy demands to deal with the crisis. And then finally, the stage of exhaustion is when after weeks or months, the depletion of fat stores in the body results in the breakdown of protein, for energy, which leads to weakening of the body and then illness. Let's talk about the pancreas. The pancreas sits behind the stomach between the duodenum and the spleen. It has both endocrine and exocrine functions. There are acinar cells that are functional with the exocrine system, and the pancreatic islet cells, sometimes called the islets of Langerhans, that contain clusters of endocrine cells. The alpha cells of the islets will secrete glucagon. The beta cells of the islets of Langerhans secrete insulin. Here's our pancreas. We've got a major pancreatic duct, and then down just before that duct empties into the small intestine at the duodenum, it's going to join with something called the bile duct. And then on the right, you can see one of the islets of Langerhans. Pancreatic hormones, the insulin and the glucagon, help to maintain blood glucose. The normal range of blood glucose is 70 to 110 milligrams of glucose per deciliter. High levels will damage blood vessels and damage kidneys and damage nerves. Low levels cause lethargy, mental and physical impairment, and even death. If you have high blood levels of glucose, so you just ate a big sugary meal, then you produce insulin. The beta cells detect that rise in blood sugar and respond by secreting the insulin. The insulin goes through the blood and leaves the bloodstream to encounter target cells. Those target cells then are going to make receptors, initiate a secondary messenger system, and then that's going to bring glucose into the cell. And then once blood glucose level falls, the beta cells stop secreting insulin. Negative feedback system. So hepatocytes, or cells of the liver, are going to respond to insulin by taking that glucose and turning it into that temporary storage form of glycogen. Adipose cells are going to take it and turn it into a long-term storage form called fat. Most cells of the body are going to increase their nutrient uptake in response to insulin. They'll have an increased amino acid uptake, increased glucose uptake. And now remember, some cells of the body, specifically the brain, does not need insulin to take in glucose. Neither do the kidneys, the liver, or red blood cells. So as blood sugar rises, we produce insulin that causes blood sugar to fall. Diabetes mellitus is an inadequate uptake of glucose from the blood. Blood sugar remains high. It's chronically elevated glucose, and that damages blood vessels, it damages small nerves. Because it's damaging blood vessels and nerves, this causes damage to the eye and the retina, to the kidney, and it's the leading cause of non-traumatic amputations in the United States. It's also associated with heart disease and stroke. Type 1 diabetes mellitus is an autoimmune disease where your immune system attacks the beta cells of the islets of Langerhans and destroys them, and so that individual can no longer make insulin. This requires treatment with daily injections of insulin. Type 2 diabetes mellitus is from decreased insulin release or an increase in insulin resistance from the upregulation of cells. Obesity is a major cause in the development, and it tends to happen to older individuals, although it's occurring in younger people. And as I mentioned earlier, you can treat it with diet and exercise and sometimes medication. We will also occasionally have what is known as gestational diabetes, seen in pregnant women, and if untreated can cause risk to the fetus and increase delivery complications. Or as somebody called it, the fetus beatus. Hypoglycemia is low blood sugar, levels below 60 milligrams per deciliter. This could be because of an insulin overdose, prolonged exercise, drinking too much alcohol, or liver or kidney dysfunction. It could be because of a deficiency of glucocorticoids or growth hormone, remember both of which boost blood glucose. Symptoms would be hunger, dizziness, confusion, sweating, and sleepiness. Why do you think sweating? Well, the body's in an emergency state. You've activated your fight or flight because you are literally dying. Glucagon is given if the individual is unconscious and unable to eat. The alpha cells of the pancreas should detect that drop in blood glucose and release glucagon. Glucagon acts through second messenger systems to cause the liver to release more glucose. It takes that glycogen, breaks it down, and releases the glucose. It causes adipocytes to release fatty acids and glycerol, which other cells can absorb and use for fuel. Glucagon does not affect proteins, and it can be given by paramedics to unconscious individuals that have low blood sugar. Once blood glucose rises, glucagon is inhibited. Again, negative feedback system. Here the stimulus is a decrease in blood glucose. The effect is production of glucagon. The glucagon is going to raise blood glucose any way it can, and then because blood glucose is higher, then that's going to turn off our stimulus and we will stop producing so much glucagon. The pineal gland is a small unpaired gland in the epithalamus of the diencephalon, so it's up in the middle of the brain. It secretes melatonin at night. Melatonin causes drowsiness. The pineal gland helps to regulate what is known as the circadian rhythm. The parathyroid glands are between 2 and 6, there's usually 4 small glands embedded within the posterior of the thyroid gland. They contain both chief cells and oxyphil cells. The chief cells are going to make parathyroid hormone, and parathyroid hormone increases blood calcium. Now, there are other tissues with endocrine functions. The thymus secretes thymic hormones, which are used in part of the immune system. The heart makes something called atrionatriuretic peptide that helps to balance blood pressure. The kidneys produce a hormone called EPO, or erythropoietin, which causes you to produce new red blood cells. The liver secretes things like insulin-like growth factors and the inactive hormone angiotensinogen. Angiotensinogen is part of a complex enzyme and hormone pathway that helps us to raise blood pressure. The stomach secretes a hormone called gastrin. Gastrin affects both the stomach itself and the pancreas. The small intestine secretes secretin and cholecystokinin. Secretin stimulates the pancreas and the stomach, and cholecystokinin stimulates secretion of bile from the gallbladder. Skin cells converts a type of modified cholesterol to vitamin D3, which is then released into the blood. D3 is a hormone that's converted to calcidiol by the liver, and then calcidiol is converted to calcitriol by the kidneys, and calcitriol is the active hormone that then raises blood levels of calcium. Adipose tissue produces a hormone called leptin. Leptin helps control appetite, and leptin also has effects on both male and female puberty and reproduction. Finally, the endocrine system changes as we age. Secretory activity wanes as we get older. We have a reduced efficiency of the endocrine system functions, and decreased levels of hormones are natural as we get older. For example, growth hormone and the sex hormones all decrease. Reduced levels of growth hormone are what lead to weight loss and loss of body mass in the elderly.